welcome. Right, okay. Ooh. There we go. Right, today I'm here to talk about CPR, which I'm sure all of you have had things to do with in the past, hopefully not too much, but it's just an overview of obviously, you know, what to do and when. Okay, so what is a crash? There are two types of crash, a respiratory or cardiac arrest. CPA, as it's commonly known, cardiopulmonary arrest. It's a cessation of breathing and absence of a heartbeat. Or we have respiratory arrest, which is where the patient is not breathing but the heart is still beating. This is the most common one that we encounter, but unfortunately this soon leads to a full CPA. Either way, any of these emergencies and we need to intervene ASAP. Okay, recognising a crash. First thing to do, is it respiratory or is it cardiac? We usually take about sort of 10 to 20 seconds to make an assessment, a check. This is where we go for our ABCs again, obviously airway. Is the airway patent or is it obstructed? Obviously CPR is very hard to do if it's obstructed. Breathing, we need to observe, feel, see if the patient is breathing or if not. And circulation. Circulation, we don't jump in trying to feel circulation straight away. Obviously, with pulses, 35% of pulses cases, people say they can still feel pulses. This is because our own adrenaline is soaring and it's actually our own pulses we are feeling. So although we do get there in the end, it's not one of the first things that comes to mind. Okay, what equipment or personnel are needed during a crash situation? So we need some monitoring, we need a crash team and we need a crash trolley. Okay, so a bit like I think you had a talk this morning on multi-parameters. So again, this is the one we use here, the Mindray. These are all the things that it does: ECG, temperature, tidal CO2, invasive blood pressure and the non-invasive blood pressure. So for our purposes, the main two things we use are an ECG and a capnograph. Now I've just put up here, I'm sure many of you know, but obviously I like to think of a way to remember which leg to put them on. I tend to go for traffic light system. I know there's a few different ones out there, but sort of red, right 4, then the yellow on the left, and then green is followed by the one behind that. I've heard all sorts of different ones over the years, but that's the one that sticks in my mind. Okay, and with a capnograph, obviously, we measure the CO2 in expired breath, which is ECO2. Now, ideally in a crash situation, we would like it to be more than 15 millimetres of mercury. Obviously on an alive wild dog, you're looking at between 35, 45. So as you can see, it's a lot less than it would be normally, but obviously any number is a good number in these situations. Okay, it also informs us of the effectiveness of our compressions. A sudden increase, so if the number suddenly shoots up, it hopefully or usually means that we've got ROSC, which is obviously return with spontaneous circulation. Okay, so the crash team. This is obviously in an ideal situation. This is sort of on a normal day when you have lots of people around. Unfortunately, as we all know, crashes usually happen at the night, weekends, or when there's not many people around. So this is ideal situation. Okay, we have a team leader, we have a ventilator, we have a compressor, a scribe, and a runner. And then anyone else that's around that can help can always swap in and out as needed. But these 5 are really the ideal amount to have. Okay, so the team leader. The team leader is usually the most senior in the room, not always, but usually. They do not actually touch the patient whatsoever. They just observe and give instructions of what to do, when and how. So they basically run the crash, tell people what to do, ask for the drugs, and also unfortunately they have to speak to the carers as well. The ventilator. Okay, so this person ensures the patient is intubated. They can either do it themselves or get someone to help them. They attach the CO2 monitor. They attach either an ambubag or a circuit. We tend to use ambubags here, but in practice you might be more circuit based. Works exactly the same. And they start breathing. So it's 1 every 6 seconds. You just basically 10 in a minute. Try to about a 1 second duration. And then again, I said, ideally, that is a well live animal. We would very, very rarely see the entitled CO2 to be that on one of our crash patients. Okay, compressor, their main job is the chest compressions. Okay, now this is a bit of a show and tell here. See if I can read it at the same time. So if we think about our little Resusci dog here, this is the ideal way we would do it. Now, first off, I haven't put it on there, but you need to think about height of the table. Okay, if you're doing compressions, having a table down here is going to be no use. So please feel free, if you have got an uppy-downy table, ask someone to raise it, lower it, stand on a whole load of cans if necessary, just to get it at the height you want it at. The ideal is to have the table at waist height. I'll put it down. Okay, so first of all, we think about our posture. Let's do it in the order, we won't see that, will you? In the order that I've put it on here. So you need to think about what you're going to be like. Okay, so I deal with the dog in the moment, but how you've got to be is, okay, so straight arms like this. We don't want any chicken arms. So if you're doing compressions with chicken's arm, you're going to be doing this, and there's no actual, oomph going for you compressions. It's all going into those elbows. So you need to have it like, think about it. If I'm doing compressions like this, you see how the table is jogging? If I'm doing it like this is my elbows. Nothing is actually happening to the table at all. Okay, bend from your waist, so it's good for your core muscles. So you take it like this. If you do it like this, you're going to be doing it all in your back and your neck, and you're going to hurt yourself because you could be doing it for quite a long time. Okay, other things to do. People all do it slightly differently. I like to lock my fingers and do it like this. Some people do it like this, but I tend to, like this. I tend to get bruises when I do that, so I tend to like this, okay? A lot of that is individual preference. Okay, going back to the patient. Oh, sorry, love. Best way to have the animal. Again, obviously now he's quite big. He is actually, I have actually got the table too high, so we'll just lower him. I'll get someone to do it for you. So, best placement is, obviously, if I have him like this, when I'm doing compressions, I'm going to do this, and he is going to be going, and he's going to end up falling off the table. So what you have to do is place his spine against your abdomen. So as he moves, you're counterbalancing it with your own body. So if we're doing compressions like this, it's pushing against my belly, which is counteracting him. So that's another thing to think about. Either side doesn't matter. It just depends on obviously where your monitor is. With us, our monitoring is always on this left-hand side. But that's something to think about, is obviously, you know, what you do. Okay, right. So the average rate of the chest compression is 100 to 120 per minute. We tend to do it for a full 2-minute cycle of chest compressions. The reason being is it takes at least a minute for uninterrupted chest compressions to obtain maximum effect. I like to think about it like climbing up a mountain. It takes you about a minute to climb up the mountain. You're doing well along the top for about 30 seconds. Then you're tired, you've got to come down again, so you then start going down the other side. So that's why we do the whole, you know, the 2 minutes of it. Okay, any longer than 2 minutes, you are tired, and it might seem like a little thing to do, but actually you tire very, very quickly. You've also got your adrenaline, which will help you, but you will tire very quickly. Okay, we compress the chest by 1/3 to 1/2 each time, and we need to ideally let the chest fully recoil before we do it again. And just I'll put a little thing at the bottom, unfortunately, ribs might break. It is something to be aware of. Unfortunately, we just have to ignore that, carry on. We can sort broken ribs out afterwards if we get the animal back. This is the sort of thing that we can sort out afterwards. Okay, so there are 4 different compression points. So your average sort of big chested dog, we call it the thoracic. So basically, anatomical wise, you can't really tell where too much is. So you basically just go over the chest somewhere. Okay, with your small sort of skinny whippety things like that, you can usually see where the heart should be beating. So then we go for a little bit further down, and that's going to be a cardiac pump, basically. Then with the barrel chested animals, with those, you can't tell where everything is. So what we do is we tend to place them on their back, again, push them against your body, and ideally in this circumstance you've got someone holding the other side to stop them, but we'll do it a bit like humans, and we'll just do it basically like that. And then I thought I'd show you my little cat and my little dog. My kids gave me this. Okay, so with them you're doing it a lot smaller. Again, you know, away from you. So if it was sort of a Yorkie size, you're probably just doing your hands a bit like this. Can everyone see? Like that. And obviously with a little kitten or something this size, you'll be just doing basically a finger and a thumb. Right. Okay, so just a little reminder of what we just said. 1 breath every 6 seconds. 2-minute cycles of chest compressions. Each time between swapping chest compressors, we will say ECG check or something like that, and we'll still stop literally 5 seconds to look what the ECG is telling us, and then we start again. Okay. There's lots of ways out there that you can keep to a rhythm with when you're doing chest compressions. One of them is Staying Alive by the Bee Gees. Another one is using a metronome. I don't know if any of you do music, but apparently this is something that's used a lot in keeping time in music. And there's a new thing which we found recently is the Recover app. This is what you can get on your phone, and it's very good because obviously you can see here, when I took a picture on my phone, it counts it down for you, but it also tells you when you've got 10 seconds left and it's time for the next person to swap in. This is a very good thing to do, and you can also hear the noise as well. Most of us have mobile phones on us at the time, all the time, so this is a very easy one to get up. And also being an app, you literally, with the metronome, you have to like go into an app to find the metronome, that sort of thing. So it's very good. Okay, next job is for a scribe. This is a very important job, but it doesn't actually have to be done by a trained nurse, vet, student nurse, anything like that. It could be anyone. Okay, it could even be a cleaner if that's all you've got around. Literally, they do not touch the patient at all. They're just in charge of writing down everything that happens. And if it was a lay person of some sort, you could help them out by shouting, you know, asystole, or I'm given atropine, or that sort of thing, and they could just write it all down at a time. Okay, it's literally just a record of what is happening. One thing they do, although with the app it does help you, is they do the timing for the 2-minute cycles. So usually, sort of 1.5 minutes, they'll say, is someone ready to swap in? Somebody who is bound to come forward, and then they'll do the 10-second countdown. So like at 1:50, they'll start counting down, and they'll say, time to swap, and people swap in. This is what we use as our resuscitation record. So as you can see, on the far side, it's got like asystole, assisted or spontaneous breathing. Then we go along to like the ECG trace, asystole, PEA, VF, pulseless. And then on this one, we can put down what drugs we've given, then any notes that happen here. Okay, then at the end, we can circle one of these. And this is kept as a record, and I think what we can do is we attach them to the animals, you know, the patient's file, you know, at the end, just so we have got some sort of record. Right, last one is a runner. This is basically does what it says on the tin. They, again, do not usually touch the animal. They will get the crash trolley ready. They will bring it over to where you are. They will draw up the drugs. They will talk a lot with the lead person, just to obviously say about obviously what drugs are needed, what rate, that sort of thing. They will also usually run to get things like fluids, blood, which might not be in the room, and that sort of thing. It says here again, they swap in if the compressor is needed. This is obviously when you only have 3 or 4 people in the building. But in an ideal situation, they will just do that. Okay, so one big thing about a crash situation is, although it might not seem the ideal time, communication is the key. Crashes, unfortunately, are very busy, very frantic. They're usually very noisy, but you have to communicate. You don't want 2 people doing the same thing at the same time. You don't want the wrong drugs given. You don't want in the wrong order, that sort of thing. So the team leader, basically, they communicate with the whole team and tells everyone what to do, when to do it, and why to do it. The runner, as well as as pulling up the drugs, they will also always double check with the team leader they've got the right drug, the right amount, and how they want it given. So basically they'll paraphrase it and repeat it back to the team leader just to make sure that is definitely what they want. And the scribe, as I said before, communicates the time and counts down the swapping in time. Right, I'm sure all of you have some sort of crash cart in practice. I know my old practice used to have like a little black box. Works exactly the same. We just have bigger and more of stuff, but your crash box will work exactly the same as ours does. So I've just put in here a picture of ours with our defib on top. So in our top drawer, basically it's like airway drawer, we have laryngoscopes, we have all the stylets, urinary catheters, all the sort of things will help you if you've got obviously a swollen airway and you're having trouble putting an ET tube down. These are all there to help you. We have a capnography adapter, cuff inflators, we also have some HMEs. And with ET tubes, we go from a size 2.5 to a 12 because obviously we cannot say what is coming in. They've also already have a tie on them, so we haven't got to worry about spending time doing that. Okay, our second drawer down is the medications drawer, which I'll go through more in a moment, but this is obviously all the medications we have in. I've put these two, one in red, one in blue, because obviously it's something to think about. The 5ml and 10ml saline flushes, you need to think about, if you are giving the animal some IV drugs, you need to think about how close is it to the heart. You've got a massive Great Dane and you've used a Sophinus, you've put those drugs in, they're not going to get to the heart, so you've got to flush them with a good, probably 5 to 10 mils flush afterwards. You've got a little chihuahua and you're doing it cephalic, you haven't got so far to go, so you can do a couple of mils. So that's something to think about. So that's why I've just put that up there in red. Pre-labelled syringes and needles, you can see them in the middle. They are, so when we draw up our drugs, we don't have to worry about labelling the syringe. We literally pull up the amount we need and hand it over, so they know what it is. So there's nothing wrong with wrong labelling, can't read someone's writing, it's got rubbed off or that sort of thing, it's all there ready. Okay, number 3, our open chest and tracheostomy drawer. Luckily we don't have to use this that much at all. We have an open chest kit, we have the tracheostomy kit in there, we have sterile japes, we have sterile gowns, we have rib spreaders, all that sort of thing that you would need. Drawer 4 is our respiratory drawer again. We have small, medium and large ambu bags. We also have paediatric and adult sized nasal prongs. Oh, and in our bottom one, we have a thoracentesis kit. And also in there, we have adult and paediatric pacing pads in case we need them. Okay, so going back to the drugs, the 4 main types of drugs we have are vasopressors, anticholinergic, never say that one, arrhythmic and reversal agents. So basically the vasopressors, these are peripheral vasoconstrictor and they constrict blood vessels, therefore they increase the blood flow to the heart. The one we use is adrenaline or epinephrine. We tend to start with low doses and it's given every other cycle. This is when the lead person will say if they want it to be doubled or they want it to be, every other cycle, that sort of thing. Okay, we tend to use this in PEA, which is pulseless electrical activity, and in asystole, which is again the sensation of electrical and mechanical activity of the heart. The anticholinergic, these are used to control bradycardia and are good at reducing vagal tone. The one we use for this is atropine, and this is used every other cycle, because unfortunately bradycardia can lead to asystole or PEA. Okay, we'll then go to the antiarrhythmic. This is not often used in crash situations, okay, because obviously in a crash situation we're usually going towards bradycardia rather than tachycardia, but we have it in there just in case it is needed. And then reversal agents, that's something you need to think about. When this animal crashed, had it had any recent drugs? That's one of the first things we try to think about. If it has, or even if it's not that recent, we will tend to reverse them. So here, these are 3 main ones we have. We've got the naloxone, which reverses the opioids. We've got the atopam, which is obviously reverses Domitor and dexdomitor. The flumazenil, which reverses midazolam and diazepam. Okay, so what do I do when I suspect an arrest? So raise the alarm, crash button, shout, scream, do whatever, try and get the attention of everybody that's around. Okay, stop all medication and fluids. The idea as well is to remove any lines from any patient. So if this cannot be done quickly, if you have T connectors, turn the T connectors off and cut the lines, break them, whatever. We can get new ones afterwards, it doesn't matter. Okay, the one thing to remember is if you need to push the little clip across, otherwise it will tend to bleed out of it. Okay, place the animal on the table, as I showed you earlier. Somebody will intubate and attach the oxygen. Someone will start chest compressions. Someone will start placing monitoring equipment on, so the ECG, the capnograph, and the scribe will start writing, and the runner comes along with the trolley. Okay, so these last 5 to 10 all happens at exactly the same time. It sounds very organised and whatever here, but basically you all just emerge at the same time. Everyone has their own jobs, and you'll just get on and do it. Okay, this is just a quick thing of the CPR algorithm. This again is by the Recover. This is a useful thing to have in your practice. You can get them online anywhere, but it's a lovely way of showing you CPR algorithm. This is the emergency drugs and dosages. Again, you can get this online from Recover as well. You might well have a sort of version in your practice. Common ECGs. So the ones on the left-hand side, you've got the ventricular fibrillation and you've got the pulseless ventricular tachycardia. With these, defib is possible. On the right-hand side, if we see any of these two, so we've got asystole or the PEA, defibrillation is not possible. It just won't work, basically, so there's no point doing it. Okay, this is a picture of our defib. You saw a little one that was on our crash trolley. It's used for internal defibrillation, external defibrillation, and external pacing. It's not used that common, but some of the things, if it is used, you need to be careful of is if there is the chance that you might be having to defib a patient. You have to be very, very careful not to use surgical spirit. If you've ever seen a defib used, when it's done, you always get a sense and the smell of burning anyway. So you can imagine that mixed with spirit is not a good combination. I have never seen it, but there are stories that animals catching light, unfortunately. So it's something that's a no-no straight away. To try and stop that burning smell, you have to put lots and lots of gel on a pad. I mean, like almost half a tub on each pad, just to help with the smell of the burning, but also it helps increase the contact as well. Okay, another thing to do is, I'm sure you've all seen ER and things like that, when they're about to defib someone, everyone shouts clear and everyone stands back and does this. Exactly the same with us as well. One thing you need to think about is moving, if animal is on oxygen, which it will be, is removing the ambu bag. Reason for this is obviously the ambu bag or circuits are quite heavy, and as you all know, animals will jump when they are defibbed, and obviously this is heavy enough to pull everything out. So the T tube will come out, or your ECO2 adapters and that sort of thing will all come out as well. So it's easier just to remove it. It's off for about 10 seconds and it all goes back on again. But obviously if it's not, you've got to go through the whole thing of intubating and everything again. Okay, something again which is not done often, and you will probably not see this in practice much. It's not a common occurrence, and we tend to do it on deep-chested dogs. These are ones that when we cannot get to that heart, we're trying to do chest compressions and we just feel it's not being successful at all. It is a massive procedure which involves opening up of the thoracic cavity. Once we're in there with a sterile glove on, we can actually massage the heart directly. You do see it more on things like ER and things like that are doing it all the time. Grey's Anatomy, most weeks they tend to do it. But obviously in animals, we don't tend to do it as much. Again, thing for this is unfortunately, if ROS does occur and the animal wakes up again, they obviously then have their chest open. They then have to go to theatre and have a thoracotomy to repair it. So it's no little undertaking. Okay, thank you for listening. Any questions?